Okay, good morning, good afternoon, good evening, everyone. Welcome to the 120th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who have just discovered us for today, welcome po. At sana po masiyahan po kayo at marami po kayong matutunan from today's topic. For today, let's talk about your liver. Experts are noticing an increasing number of individuals who present with asymptomatic liver disease and abnormal liver profile tests. And upon examination and testing, this may be non-alcoholic fatty liver disease that can remain benign, but may also progress to severe disease such as cirrhosis and liver failure. So ang mga katanungan po natin for today, what causes fatty liver? Can it be prevented? How and why can it become more serious as a disease? Can it be managed? And when should a general practitioner refer patients with abnormal liver profiles to the specialists? I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And always looking forward to hosting our Fridays with my beloved mentor, our adjunct research faculty at the National Telehealth Center, also international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat. We'd like to welcome you to the webinar. Nice to see everyone saying something in the chat box. Natutuwa kami that you're all okay and that you're here with us to learn something about your liver. Okay, so maganda ang ating pag-uusapan ngayon. I'd like to welcome also those who are watching on Facebook and on YouTube, and also those who are watching on the playback. We realize that not everyone can make it at lunchtime for the Zoom meeting, Raymond, but we have a good number of people who do come in on the playback, and we're very happy that we're able to help you in whatever way in terms of getting more information about health, and preventing disease. So we've got a very exciting topic, and of course, exceptional, the best speakers. Alam nyo naman yon na, we go out of our way to find the best speakers, and these speakers go out of their way to give you the best possible presentation. Talagang kinakarir nila ito, no? So good for us to also let you know that more people are going to be able to see Stop COVID Deaths, because we are going to be on channel 101 on your television set. So that's TVUP, Signal TV channel. Yan. Okay, so Monday to Sunday, every day, 24 hours TVUP. Hindi naman po 24 hours kami, May iba-ibang show yung TVUP. Sobra na yun, Raymond, no? 24 hours yung Stop COVID Deaths. But it's really great to have that platform, that ability to reach more people. And we hope to be able to continue to give you good content, no? At siguro you can also go and see some of the past episodes by just going to channel 101. Okay, so you've also noticed that in the opening billboard, we say Stop COVID Deaths. As we started before, this was only about COVID. Pero ngayon, the C stands for COVID. We still continuing COVID issues. We still take that up. O for other infections, other outbreaks, V for viruses, I for infections, and D for disasters. So we've broadened our discussion, and as it is today, we're going to talk about something that's not talked about a lot, but we all need to know more about our liver and the increasing number of people who develop fatty liver. So we are going to bring you very good experts today, and we'll have a great discussion. Meanwhile, we know that most of you are really looking forward to credible news. Marami pong balibalita dyan na hindi naman maganda talagang source. But actually, Raymond is the one who prepares this. We go out of our way to find the latest information for you, and we have this section called the News Update.
Okay, for our first news update, we will be tackling the question, why is short-sightedness on the rise? Marami po talaga sa atin, well, maybe in the 80s and 90s, we have heard that those who are living in Singapore, lalo po yung mga magulang, they were increasingly getting more and more concerned because a lot of their children were becoming short-sighted. Today, Singapore has a myopia rate of around 80% in young adults and is now considered the myopia capital of the world. Yung pong short-sightedness sa buong mundo. In the United States, in comparison, 40% of adults are short-sighted, which is up from 25% since the early 1970s. Ganon din po ang itinaas sa United Kingdom, South Korea, Taiwan at mainland China. Yung kung saan po yung prevalence rates naglalaro between 84 to 97%. If current trends continue, 50% of the world's population will be short-sighted by the year 2050. So ano po in less than 30 years time, marami na kalahati na po ng mundo ang magkakaroon po ng problema sa kanilang eyesight. Myopia has risen dramatically among children in China, from as much as 76% all the way to up to 90% among older school children. So napaka-steep po, no? Napakataas po ng pagtaas ng mga kaso. And it's become one of the leading causes of vision impairment and blindness and has affected children's ability to learn in school and enjoy daily life. So ang katanungan po, ano po ba ang nagkokos ng global eyesight crisis? Maliit po na porsyento rito ang dahil sa genetics. Mas malaki po rito ang lifestyle factors. In particular, a lack of time spent outdoors and focusing on close objects for an extended period through an activity such as reading or watching or using yung pong screen time na tinatawag. So hopefully we'll be able to focus on more positive, measurable health effects, maybe get some more time under the sun, so to speak, and not really do any activities or engage in any activities that consistently hurt our eye health. Over to you, Dr. Susie.
Wow, that's very interesting, Raymond. Okay, so from medical news today, long COVID. Scientists find 20 blood protein signatures that may point to risk. So we know that long COVID is more common among hospitalized patients, but 36% of non-hospitalized patients without a clinically severe infection can develop long COVID. So how do we get long COVID, or how would we know if we are at a higher risk for getting long COVID? Well, research has been conducted showing that blood protein levels within 6 weeks of contracting SARS-CoV-2 would predict long COVID incidence. And after analyzing the data, researchers have found that those who tested positive for SARS-CoV-2 virus with an increased number of specific proteins that are involved in oxidation stress, metabolic reprogramming, and cell adhesion are likely to get long COVID. So that's our news for this week. And next week, we'll bring you more updates on the news update. Okay, we're back, Raymond, and we are going to talk about some of the risk factors of COVID-19 that are related to liver disease, no? So aside from talking about fatty liver, we will also talk about how fatty liver is linked to metabolic syndrome, which means overweight, obesity, diabetes, dyslipidemia. It's estimated that as many as 1 out of 3 Filipinos could have a fatty liver. So the question is, what can I do to reduce the risk of chronic and severe illness, and why should I care if I have a fatty liver? Okay, hindi naman nakikita daw yun eh. No? So I think we'll have a very interesting discussion. But before that, Raymond, we asked some questions to persons on the street. Raymond, please.
That's correct. That's correct, Dr. Susie. For all those who are joining us for the very first time, we usually set our discussion into context by presenting you with a short video produced by the TVUP and the webinar team. The question that we pose to our interviewees, folks on the sheet po, no? Narinig nyo na po ba ang fatty liver? At ano po sa tingin ninyo ang ibig sabihin nito? Please watch this.
Ever, hindi ko pa po siya naririnig. First time ngayon.
Yan ata yung taba sa atay.
Una pong pumasok sa isip ko, fatty liver as in yung pagkain. Liver na mataba. Pero kung sa tao, siguro ibig sabihin niya unhealthy na liver.
Based on what it sounds like right now, it's unhealthy fats that are not supposed to be on the liver.
Nakukuha sa sa pagkain na madami at saka sa pag-inom ng alak.
Pag sobrang barbecue, pag-inom ng alak.
Problems with fatty liver is that it's hard to diagnose and there are not a lot of symptoms, especially when you're at its early stages. But if you let it go untreated and you let your liver store more and more fat,
may lead to inflammation. Tapos itong inflammation na to may eventually scar your liver. And yung sa huli na yung cirrhosis, which is yung it can actually the scarring can actually limit the functioning of your liver. So yun yung delikado na talaga.
Siguro po sa unhealthy eating habits, tulad ng pagkain ng sobrang mataba at pag-inom ng sobrang alak.
Siguro sa sobrang ng alak sa acid.
Since it's inside the body, I assume it's from unhealthy eating lifestyle.
Tinatry ko pong mag-exercise, tinatry ko pong isingit sa aking academics. At as much as possible, tinatry ko rin pong kumain ng healthy na kaya sa budget.
Kumain ng mga masusustansyang pagkain.
Tamang diet, tanggal inom. Yun lang siguro.
The usual, just eat a balanced diet, exercise, drink a lot of water.
You have to do lifestyle change. So it may be in the form of change in your diet, change in your exercise routine, or especially stop drinking alcohol din. Especially kung alcoholic yung cause ng iyong pag-accumulate ng fats sa liver.
the best way to not only prevent fatty liver, but if you have the condition, to reverse the effects of it, is definitely to have some lifestyle changes, avoid alcohol, or eat healthier food, eat less fats, of course.
Okay, thank you very much. TVUP, always very interesting to hear. Tsaka ang galing ng mga iba, no? Thank you, TVUP, for those interviews. I think, Raymond, you have some housekeeping before we proceed. Go ahead, please.
Yes, thank you, Dr. Susie. For those who are wondering kung bakit di po sila nakatanggap ng kanilang certificates, we just want to let you know that we have distributed certificates for webinars 1 to 118, and maybe a very few na lang po ng mga certificates for webinar 119, which should be finished within the next 24 hours. If you feel that you should have received a certificate of attendance, even if you have attended po more than 50% of the webinar duration, tas wala po kayong certificate, please email us at stopcoviddeaths@up.edu.ph. For today's webinar, we'll be having our standard panel discussion format. After our speakers have presented, we will be moving on to a Q&A session wherein we'll be entertaining questions from the Zoom. And then if there are any questions in the chat box po ng Facebook, pati na rin po sa YouTube, we will be scouring them and selecting which questions we'll be posing to our panel of experts. But before we delve into the webinar, we have our cute intro for our fun quiz segment.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na! Okay, nakakatuwa naman. Nakakatuwa naman talaga. Natatawa ako, Raymond, eh. Parang ano ba yan? It's cute, okay, but I know most of you really look forward to this part of the webinar. So let's take it away, Raymond. Question number 1.
Thank you, Dr. Susie, for our first question. Which of the following risk factors or conditions are associated with fatty liver? Isa lang po ang tamang kasagutan. Nandito po ay option A, diabetes. Option B, hypertension. Option C, obesity. Option D, dyslipidemia. And option E, all of the above. We'd like to take this opportunity to greet those who are joining us all the way po, no, from the World Health Organization in Philippines po, Santa Cruz in Manila, Municipal Health Office in Balete, Aklan, Eleuterio T. Decena Memorial Hospital in Hinobaan, Negros Occidental, Edwin Andrews Air Base Hospital in Zamboanga City, Davao City Health Office in Davao Region. Meron din po tayong nanonood from the Quirino Memorial Medical Center Laboratory, and our regulars from the University of Santo Tomas po sa endoscopy unit. For our second question, how common is non-alcoholic fatty liver disease? Isa lang din po ang katamang kasagutan. Is it 5%? Is it 10%? Or 35%? Or is it as much as 60%? For those who are outside of the Zoom, you may also participate din po sa ating fun quiz by opening up your browsers, typing in slido.com, and inputting the code when prompted 5405717. That's 5405717 for you to be able to participate. Okay? We'd like to greet those who are joining us from the Changhua in Taiwan, our attendees from Bangkok, Thailand, from Canton City, Vietnam, from Qasim University Medical City in Saudi Arabia, from the International SOS Luanda in Angola, from ARMMC in Marikina City as well, and Rizal Medical Center. Maraming salamat po. And for our third and final question for today's fun quiz, most patients with fatty liver have, number 1, do they experience pain? Number 2, do they experience vomiting? Number 3, do they experience jaundice? Or number 4, wala po silang nararamdaman. Isa lang po ang tamang kasagutan sa lahat ng ating questions, including question number 3. We won't be closing our fun quiz as we move on to our webinar proper. Dr. Susie?
Okay, thank you very much, Raymond. No? Parang mahirap yung mga tanong. Pero okay lang. Mukhang, mukhang yung iba sa inyo, ginugoogle nyo na. Very good. Okay. I know we're excited to get on to our expert, and we indeed have an expert today. He is a leading expert in gastroenterology, and he is associate professor from the Division of Gastroenterology in the Department of Medicine, UP Philippine General Hospital. Let us give a warm virtual welcome to Dr. Janus P. Doc Janus, welcome. Uy, palakpakan.
Hi. Yes, hi. Good afternoon. Good afternoon po.
Palakpakan. Okay. Sige, Janus, go ahead with your presentation. I know people are waiting to hear from you. Yeah, go ahead, please.
Okay. Thank you. Let me just share. Oops. Okay. All right.
There we go.
Okay. Thank you very much. Good afternoon. I would like to thank the team behind the Stop COVID Deaths webinar series, Dr. Sarmiento and Dr. Susie Pineda, for the invitation, and also the Chancellor, by the way. Sorry, she was the one who first asked me to be a speaker in this webinar series. My assignment today is to talk about fatty liver, and we have titled this talk, Fatty Liver, Why Should I Care? These are my disclosures. So when we met to plan this webinar, the organizers had asked if I could share some typical or even not so typical cases of fatty liver that are seen in the clinic. So a typical case is shown on the slide. A 45-year-old female with no comorbids had an executive checkup because this was a benefit offered at work, and she was asymptomatic, does not drink alcohol. Her exam is unremarkable except for a BMI, body mass index of 26, which is obese by Asia Pacific standards. Her blood tests were also unremarkable except for slightly high ALT or SGPT, and she was negative for hepatitis B and C. Her ultrasound showed fatty liver, and a fibroscan was done that showed a cap of 300 indicating fatty liver, and a liver stiffness measurement of 5.8 kPa, which indicates minimal or no fibrosis. We'll hear about that later as well. So her diagnosis was non-alcoholic fatty liver disease, or NAFLD, low risk for complications because of the absence of significant fibrosis. So as you can see from the pyramid on the left, most of the patients that we see in clinic are very similar to her case. A less typical case, of course, is this case of a 58 male, overweight with metabolic syndrome, presenting with biliary colic. So they have diabetes, hypertension, and dyslipidemia. Underwent laparoscopic cholecystectomy for the biliary colic, and there was incidental finding of a cirrhotic liver. His workup for cirrhosis was negative for Hep B, C, autoimmune liver disease, iron overload, or other liver diseases, and he denied significant alcohol use. So the diagnosis was cryptogenic cirrhosis, and in the setting of metabolic syndrome and a negative workup for other liver diseases, this is likely NASH-related cirrhosis. Fortunately, cases like this are less common compared to the previous one. The last case is pretty much similar to the previous slide, except this patient presents with abdominal pain, is found to have a liver mass on ultrasound. On further workup with a CT scan and other tests, this was determined to be hepatocellular carcinoma or liver cancer. Therefore, compared to the other one, this is likely NASH-related cirrhosis with a hepatocellular carcinoma or liver cancer. So fortunately, again, this type of patient is even less common than the previous patient that I showed. However, because of the sheer number of the universe of patients with fatty liver, the number of patients that will end up with end-stage liver disease and liver cancer from fatty liver is still quite a lot. So the challenge, of course, is to prevent the progression of fatty liver to this stage. So in this talk, I hope to be able to share with you the burden of NAFLD, its natural history, its diagnosis and screening, and more importantly, risk stratification and its management. Again, I will be talking about NAFLD or non-alcoholic fatty liver disease. We won't be talking about alcoholic fatty liver disease, which was mentioned by some of the folks on the video earlier during the webinar. Let us start with the burden of liver disease. But first, a bit of history. I think for the more mature in the audience, like myself, we were always taught in medical school that fatty liver is benign. It was not until around 1979, maybe 1980, when two separate groups of researchers first described that fatty liver was not that benign after all. And since 1979, there has been an explosion in the number of yearly publications on NAFLD in our knowledge of NAFLD, from its epidemiology all the way to the management of the disease, although we still await the approval of the first pharmacologic agent to be used for NAFLD. NAFLD is not one disease. It is a spectrum of conditions or clinical pathologic conditions that includes non-alcoholic fatty liver or NAFLD or simple steatosis and non-alcoholic steatohepatitis or NASH, which is the progressive form of NAFLD that can progress to NAFLD-related cirrhosis and NAFLD-related hepatocellular carcinoma. So the difference between simple steatosis and NASH is the presence of liver injury in patients with NASH, that is, the presence of inflammation and hepatocyte ballooning as indicators of injury in the liver of patients with NASH. So NAFLD is now the leading cause of chronic liver disease in many parts of the world. This slide shows the worldwide prevalence of NAFLD in the general population to be about 25%, with the highest prevalence in South America and the Middle East and the lowest in Africa. In an ultrasound-based study, the prevalence of NAFLD in a wellness clinic in Metro Manila was found to be quite high at 38%. Because NAFLD is often associated with metabolic conditions, the prevalence of NAFLD is expected to be higher in patients with these conditions. This slide shows the worldwide prevalence of NAFLD among diabetics to be about 55%. In the same study from Metro Manila, the prevalence of NAFLD among diabetics was pretty similar to global estimates at 57%. The prevalence of NASH, however, which is the progressive form of NAFLD, however, is more difficult to estimate because, as I mentioned, we need to demonstrate liver injury and it requires a liver biopsy. But estimates are that between 1.5 to 6.5% of the general population worldwide have NASH, and among diabetics, 37% of them have NASH or the progressive form of NAFLD. So not only is NAFLD very common, over the next decade, the prevalence of both NAFLD and NASH is expected to increase further, which will be driven mainly by the increases in the prevalence of obesity and diabetes. More importantly, NASH has become the most rapidly increasing reason why liver transplants are being done around the world. It is also becoming the most fast becoming a very important cause of liver cancer worldwide. In the Philippines, we see two cohort studies from 2010 and 2016, and we see an increase in the proportion of liver cancer from NAFLD from 1% in 2010 to 11% in 2016. So NAFLD is also associated with poor health-related quality of life compared to the general population. And this impairment in quality of life we can observe regardless of whether they have severe liver disease like cirrhosis or whether they had mild disease and just fatty liver. However, despite the fast-growing importance of NAFLD, there remains to be a low level of awareness and knowledge among the public, even among those with metabolic conditions who are those that have the highest risk to develop NAFLD-related complications. In a recently published global survey of physicians from various specialties, a significant knowledge gap has also been observed in the identification, diagnosis, and management of NAFLD, especially in the primary care setting where most of the patients with NAFLD are seen. However, it is concerning that in a global survey of more than 100 countries to determine how prepared countries are to handle NAFLD, no country scored 50 or higher on the NAFLD preparedness index, and in fact, a third scored 0. So the authors concluded in this survey that no country at the present time is prepared to address NAFLD. Because we are still in the COVID-19 pandemic, I just wanted to include one slide on the impact of NAFLD on COVID-19. One concern, of course, is whether NAFLD changes the outcome in patients with COVID-19. This meta-analysis showed that while NAFLD was associated with increased COVID-19 severity and ICU admission rates, NAFLD did not increase mortality in COVID-19 patients after adjustment of other confounding factors. So let's move to the natural history of NAFLD. The slide shows the natural history of NAFLD, how NAFLD progresses, both NAFLD or simple steatosis and NASH can progress to advanced fibrosis or cirrhosis, although at very different rates, with NASH being the main driver of fibrosis. Among those with liver fibrosis, 22% will develop cirrhosis, and 19% of those with cirrhosis will develop complications of liver disease like liver cancer and decompensation with ascites and encephalopathy over 2.5 years. NAFLD is now considered to be a multi-system disease. NAFLD patients, aside from being at risk for liver disease, liver cirrhosis, and liver cancer, can also develop multiple extrahepatic complications such as cardiovascular disease, diabetes, chronic kidney disease, and extrahepatic malignancies. This bidirectional relationship, it's believed to be bidirectional, is believed to be mediated by insulin resistance, vasoactive thromogenic molecules, and pro-inflammatory factors. So just to illustrate, in this meta-analysis of 16 observational studies, NAFLD patients had a higher risk of non-fatal and fatal cardiovascular events compared to patients without NAFLD. And this risk was higher in those who had severe NAFLD. And it remains statistically significant even after adjusting for traditional risk factors for cardiovascular disease. With respect to NAFLD and extrahepatic cancers, a cohort involving 4,000 NAFLD patients and 14,000 matched controls showed that patients with NAFLD had an overall twofold increased risk for cancer compared to those without NAFLD. And the most common extrahepatic cancers in NAFLD patients were cancers of the GI tract, breast, and the uterus. So in fact, when you look at the causes of death among NAFLD patients, several cohort studies have found that while cirrhosis and HCC are important causes of death in NAFLD, which is obvious, cardiovascular disease and extrahepatic malignancies are actually still the leading causes of death in patients with fatty liver. It appears that the severity of liver disease determines the likely cause of death in patients with NAFLD. In this study from Cuba, patients with cirrhosis were more likely to die from liver-related deaths or complications, whereas those who have less severe fibrosis or bridging fibrosis were more likely to die from non-liver or cardiovascular disease and extrahepatic cancers. So if we go back to the natural history slide, we can modify slightly the natural history to show that while liver failure and liver cancer are important outcomes among patients with NAFLD-related cirrhosis, cardiovascular diseases and extrahepatic cancers appear to be as important or more important causes of death in NAFLD patients with less advanced liver disease, highlighting the importance of incorporating aggressive control of metabolic conditions and age-appropriate cancer screening in the management of all our patients with NAFLD. Let us move on to the diagnosis, screening, and risk stratification. So the diagnosis of NAFLD requires the presence of fat in the liver, either by ultrasound imaging or biopsy. There should be no significant alcohol use. There should also be no secondary causes of fatty liver, like medications. And there are no other causes of other liver diseases. And patients often have associated metabolic conditions like diabetes. NASH is diagnosed, however, only by liver biopsy, as I mentioned, because we have to demonstrate the presence of tissue injury together with fat in the liver. A frequently asked question is, who should be screened for NAFLD? Screening in the general population is not recommended at this time. However, most of the liver societies around the world, and now the endocrine societies such as the American Diabetes Association, and this year the American Academy of Clinical Endocrinologists, recommend screening in patients who are high risk to have fatty liver and its complications. These are the patients with type 2 diabetes, metabolic conditions, and those with persistently elevated liver enzymes. The reason these groups have been singled out for screening is primarily because these groups are at high risk for NAFLD-related fibrosis and or for progressive liver disease. Patients with type 2 diabetes have a higher prevalence of fibrosis compared to those without fibrosis, without diabetes. Patients with 2 or more metabolic conditions have a higher risk for progression to cirrhosis or liver cancer. And patients with NAFLD and elevated ALT or SGPT that's persistently high have a significantly higher risk of progression to cirrhosis and liver cancer. So once we diagnose NAFLD, it would then be important to stratify our patients into those who are either at risk, at low risk, or high risk for adverse clinical outcomes. Because not everyone with NAFLD should be referred to a specialist. I think there are not enough specialists to see all the NAFLD patients besides. Low-risk patients, which is the majority of patients, can be managed very easily in the primary care setting, and high-risk patients may benefit from referral to a specialist for further risk stratification and management. In order to risk stratify our patients with NAFLD, we need to know what predicts outcomes in NAFLD. And it's been found that liver fibrosis has been consistently the most important predictor of clinical outcomes in patients with NAFLD. This meta-analysis showed that fibrosis stage was associated not only with liver-related mortality, but also with all-cause mortality, even after you controlled for confounders such as age, sex, and comorbidities. This increased risk can be demonstrated as early as F2 fibrosis or stage 2 fibrosis, which is considered to be significant fibrosis. So those findings highlight the importance of the assessment of fibrosis severity being a very important part in the clinical management of all the patients that we see in the clinic with fatty liver or NAFLD. So how do we determine fibrosis in NAFLD patients? Liver biopsy has been a traditional way to determine fibrosis. However, it is not ideal because it is invasive, it can be painful, it can be expensive in some parts. It's associated with finite risk of morbidity and mortality, and with sampling and observer variability. A liver biopsy is also something all of our patients want to avoid. So we turn to non-invasive tests, which have been increasingly used in the liver disease world in fibrosis assessment to replace liver biopsy. And this slide shows the commonly used non-invasive test for liver fibrosis. This slide shows the ones that are available locally. The commercial biomarker liver fast is available here, but it's limited in terms of availability and is relatively expensive. There are cheap alternatives that are blood-based, such as FIB-4, NAFLD fibrosis score, the APRI, and the AST-ALT ratio, which use the usual lab tests that we order for all of our patients with liver disease, such as ALT, AST, and platelet count. Among the imaging biomarkers, vibration-controlled transient elastography or FibroScan, you'll hear more about this, I'm sure you hear about it already, is more widely available than shear wave elastography. So which one of these commonly available or available non-invasive tests of fibrosis performs the best in fatty liver? In an individual patient data meta-analysis, vibration-controlled transient elastography or FibroScan and FIB-4 among the blood biomarkers perform the best among all of these non-invasive tests. What is FIB-4? FIB-4 or Fibrosis-4 Index incorporates age, platelet count, AST, and ALT in the formula shown on the slide. You can very easily calculate the FIB-4 index using smartphone app calculators like MDCalc, for example, or QX Calculate, a screenshot of which is shown on the slide. So what is vibration-controlled transient elastography or FibroScan? FibroScan is shown on the slide. That's the machine that we use. Is an ultrasound-based technique that measures liver stiffness in kilopascals, and the liver stiffness that's measured correlates with the severity of fibrosis. How do we interpret FIB-4 and FibroScan results? A well-known characteristic of non-invasive tests is that they are more reliable when they're in the extreme values, so either very high or very low. Low values, which is less than 1.3 for FIB-4 and 8 kilopascals for FibroScan, excludes advanced fibrosis, and high values, which is greater than 2.67 for FIB-4 and 12 for FibroScan, indicate high risk for advanced fibrosis. Values in the middle are generally less reliable and so are considered indeterminate results. So how can we then decrease the number of indeterminate results so we can optimize the use of non-invasive tests? We can do sequential testing, which is performing a second non-invasive test only on those who previously had indeterminate results on the first non-invasive test. And this has been shown to reduce the number of indeterminate results and allow the classification of a larger proportion of patients into high-risk or low-risk groups. So how do we put it all together? On the slide is an algorithm, and there are similar algorithms available. This one is from the American Gastroenterological Association, which is meant to be used in the primary care setting. First, we identify patients who should be screened for NAFLD, and we've identified those. Those are those with high risk for fibrosis and for severe liver disease. Patients who have diabetes with 2 or more metabolic risk factors or persistently high SGPT. So once we confirm NAFLD, we then determine fibrosis stage using a non-invasive test. FIB4 is recommended as the first line non-invasive test because it is reliable and cheap. You only need the AST, the ALT, the age, and the platelet count. Those with a low risk on FIB4 can be followed in the primary care setting, while those with high risk can be referred to a specialist for co-management. Those with indeterminate result on FIB4 can be subjected to a second non-invasive test, such as FibroScan, if available, and triage according, again, to the risk category. Intermediate risk patients, after 2 sequential tests, can either be referred to specialist care or be monitored with reevaluation in 2 to 3 years. Lastly, let us touch a little bit on management. So because of the strong association between obesity and the metabolic syndrome with NAFLD, all the major liver society guidelines recommend lifestyle modification, which includes dietary change, weight loss, and structured exercise intervention as the cornerstone in the management of NAFLD. They all agree that a caloric deficit of 5,000 to 1,000 kilocalories per day should be the goal to achieve a weight loss of 7 to 10% of baseline weight over 6 to 12 months. I'll explain a bit later with one slide why 7 to 10% is the magic number. There are limited data on macronutrient diets and their efficacy in NAFLD because that's often a question that patients have. Should I go on a keto diet and what other diets? So the European and the Asia Pacific guidelines suggest a Mediterranean diet if one really wants to have a type of diet that they want to follow. And of course, a Mediterranean diet is not an easy diet to follow and can be expensive. But if you look more closely at the Mediterranean diet, what it is that it is low in saturated fats and in reduced sugars and also refined carbohydrates, because it emphasizes the avoidance of fast food or processed food and having more home-cooked meals. So if it is hard to follow a Mediterranean diet strictly, just remember that the key really is to lose weight. So caloric restriction is really important. And if there are foods that you want to avoid, this should be avoiding saturated fats and sugar-sweetened beverages. So dapat wala na yung mga C2 or yung mga juice boxes. And if one needs to have a substitute for olive oil, because olive oil can be expensive, I think canola oil may be a good alternative because like olive oil, it is low in saturated fat and high in monounsaturated fats. Next is exercise. Moderately intensity exercise that can either be aerobic exercise or resistance training is recommended. The choice as to aerobic or resistance training should be according to patient preference so that it can be sustainable in the long term. If the patient doesn't want to do aerobic exercise but wants to do resistance training, so be it. At least they can sustain that in the long term. Many patients would ask, what is moderate intensity exercise? So on the slide are examples of activities that are considered moderate intensity: brisk walking, recreational badminton, tennis doubles, light cycling, and swimming laps. So some activities that we normally do not consider to be exercise may already be considered exercise, such as washing your car for 45 minutes to 1 hour, gardening for 30 to 45 minutes, and for those who like to dance, dancing for 30 minutes. The US Department of Health and Human Services physical activity guidelines state that moderate intensity aerobic physical activity means that you're working hard enough to raise your heart rate and break a sweat. One way to tell if it's a moderate intensity aerobic exercise is that you'll be able to talk at the end of the exercise but not sing the words to your favorite song. So pwede ka pang magsalita pagkatapos mag-exercise pero hindi na pwedeng kumanta. Bariatric surgery can be considered in patients with NAFLD who fulfill the usual eligibility criteria for bariatric surgery. However, the decision to do bariatric surgery must not be based on the presence or absence of NAFLD. So, as I mentioned, why do we target 7 to 10% weight loss? This important prospective study on lifestyle modification in NASH, where liver biopsy was performed before and after lifestyle intervention, showed that while liver fat disappears with weight loss of 3 to 5%, it is only when a weight loss of at least 7% is achieved that there is resolution of NASH and, more importantly, reversal of liver fibrosis. Let us go to pharmacotherapy in NAFLD and NASH. It is important to remember that there is no approved drug for NAFLD or NASH. At this time, recommendations are mainly given for the off-label use of vitamin E and pioglitazone only in biopsy-proven NASH. Promising therapies for NAFLD and NASH include obeticholic acid, which has been shown to reverse fibrosis in a large RCT, but it was associated with significant itching and an increase in LDL levels, so it has not been granted approval pending more data. Because NAFLD is closely linked to diabetes, diabetes therapies have been studied for NAFLD. There are 2 diabetes therapies that have shown promise recently in NAFLD, in addition to pioglitazone. Glucagon-like peptide 1 analogs and the sodium glucose cotransporter 2 inhibitors. Proof of concept studies have shown benefit for these 2 drug classes for the resolution of NASH, but these results require confirmation in studies with larger sample size and longer follow-up, which are ongoing. The slide also shows the drugs that have been shown to be ineffective, not effective for NAFLD or NASH, which includes metformin, ursodeoxycholic acid, statins, and omega-3. Metformin and statins, however, are very useful drugs in patients with fatty liver and should be used for the metabolic conditions seen in NAFLD patients. So the next series of slides, just a few more slides, illustrate an approach to NAFLD patients. Again, lifestyle modification to control overweight and obesity in NAFLD is the cornerstone. We then need to aggressively treat the associated metabolic conditions such as diabetes, hypertension, and dyslipidemia, because cardiovascular disease is still the leading cause of death among NAFLD patients. We should consider GLP-1 analogs and SGLT2 inhibitors for diabetes and statins for dyslipidemia when indicated. Then we consider liver-directed treatment in those with biopsy-proven NASH with vitamin E and or pioglitazone. And lastly, we consider giving drugs that can potentially reduce complications of cirrhosis, such as statins to reduce portal hypertension, and metformin to prevent HCC. These are really more considerations for the specialist and not for the primary care physician. Ultimately, because NAFLD is considered a multi-system disease, its management will require a multidisciplinary team approach with multiple specialists coming together to provide holistic care to patients with NAFLD to achieve optimal outcomes. One approach is to have a dedicated fatty liver clinic within institutions, providing a one-stop shop-like setup with the patient at the center, which would then lead to improved patient outcomes. So, in summary, chairs, fatty liver, why should I care? Because NAFLD is an important public health problem, and it can lead to cirrhosis, liver failure, and HCC. And being a multi-system disease is associated with cardiovascular disease, chronic kidney disease, diabetes, and cancers. Fibrosis is the most important predictor of clinical outcomes in NAFLD, so we need to determine fibrosis severity in all of our patients with NAFLD that we see in clinic. If there's one thing that we should really remember from this talk is to evaluate our patients who come in with NAFLD for fibrosis, so that we can determine how intensively we are going to monitor them and counsel them on lifestyle modification. Lifestyle modification is the cornerstone in the management of NAFLD. Pharmacologic therapy, off-label, can be considered for some patients, and aggressive management of associated metabolic conditions is an important component in the multidisciplinary approach to NAFLD. Thank you very much, and thank you very much for your attention.
Oh, thank you so much, Dr. Janus Ong. Nako, you can see yung mga palakpak and the hearts coming out. And our virtual clapping. Saan ba yung palakpakan natin? What an excellent, comprehensive presentation. I learned so much just listening to you, and I'm sure our audience also picked up a lot. And we're going to have a good discussion later in our Q&A. So for those of you who have questions, you can put them already in the Q&A box, but I can already see some questions and comments on the chat. So we have one more speaker. So Raymond, over to you.
Thank you, Dr. Susie. And thank you so much, Dr. Janus. Very interesting. Caloric restriction is the key. That's my main takeaway. Thank you so much. For our next speaker, hindi na po siya kaila sa inyo. I think we've had her at least once in our webinar. But before that, I just wanted to reiterate the suggestion of Dr. Susie that if you have any questions, please feel free to put them in the Q&A box of the Zoom and in the comment section of Stop COVID Deaths or TVUP Facebook pages or TVUP YouTube channel. We'll be choosing which ones, especially those that have been repeatedly asked or upvoted po, no? And be the ones that are selected that we will post to our speakers. And right now, it's my pleasure to introduce to you our next speaker. She's an attending with the PGH's Division of Endocrinology, Diabetes, and Metabolism. Please welcome to your screens, Dr. Elizabeth Paz-Pacheco. Dr. Beth?
Yes, hello. Good afternoon, everyone. And congratulations, Dr. Janus. You actually said it all. It was a very comprehensive and really educational, informative lecture. Hello to Dr. Susie, Raymond, our Chancellor, and all our colleagues at the UP. And you correctly reminded me that I was one of the first speakers way back at the beginning of the COVID.
Yes, ma'am.
Be back. Okay, so let me now share my screen just to give you a little bit of a reaction to what Janus already so beautifully described for all of us. And maybe my point here basically is really from my perspective as an endocrinologist, maybe focus a little bit more on NAFLD and its association with the metabolic syndrome. That's another really big term, and that's been in our consciousness for the past 20 years or so, and I'll try to give you some of these details as we go along. So these are my disclosures. Some drugs I'll be mentioning are actually going to be coming out from guidelines and are not my own. And I will try to also talk about a little bit about the diets that have been thought of to be able to help us in ameliorating liver fat. Okay, so when we talk about the metabolic syndrome, clearly here you can see that metabolic is a cluster of risk factors. And again, as I said, it's over 20 years or so that many people have been interested in this constellation or cluster of factors. And truly, over the years, therefore, there came out a so-called harmonized criteria. So this is a simple clinical criteria that you and I in the clinics every day may be able to apply. The way it works is that you look at your patient, do your usual anthropometrics and blood pressure determinations, and do a few basic laboratory tests, blood sugar and lipids included. So there are 5 items here that you look at. You measure the waist circumference, and there are population and country-specific definitions. You measure the blood pressure, 130/85 is your magic goal. You look at blood sugar. 100 is the cutoff for beyond which patients no longer have normal blood sugars. And then you look at triglycerides and your HDL in terms of lipids. And triglycerides of greater than 150 milligrams per deciliter. And a reduction of your HDL, which are gender-related, less than 40 for males and less than 50 for females, then become your guide in terms of this definition. You don't need all of them. You actually need to look at 3 out of 5 of these particular measures for you to say that your patient does have the metabolic syndrome. So it's a simple way of defining, and you can do it, as I said, every day when you see your patients in the clinic. Now, the association with NAFLD is really clear in terms of the role of key components here, which are glucose and triglycerides. And I will go in to explain to you in a greater detail how it really impacts all of these outcomes and consequences. And obviously, as Janus has said, it's already a bidirectional consequence as it relates to metabolic conditions, diabetes, cardiovascular disease. And on the other hand, non-alcoholic steatohepatitis, fibrosis, and eventually hepatocellular carcinoma, all of which we don't want to see in our patients. So here is an illustration that several years. I think it more or less covers what we need to understand in terms of looking at what causes or what is the pathophysiology of NAFLD in the setting of metabolic syndrome. Here you can see the guy who probably, like many of us, are enjoying our food so much and not doing our physical activity programs regularly. And therefore, as a result of that, you would see that an increase in obesity, which for the most part, for Filipinos particularly, is more of a visceral adiposity. So it's not subcutaneous fat, but instead visceral fat, which is the more cardiometabolic component of our fat. And what happens here is in the setting of an increase in eating, particularly excess refined sugars, you then convert these sugars into intrahepatocellular triglycerides here in the liver through a de novo lipogenesis pathway. And therefore, here you will see a lot of deposits of the fat into the liver. This will then show a lot of manifestations, such as an increase in your transaminases. And then, of course, the action of insulin now becomes impaired at the level of the adipose tissue here on the left side of the figure, indicating that here the adipose tissue now is hypoxic and becomes really resistant to the action of insulin. And what that does over time is that you're not able to promote your non-esterified fatty acid release, as well as there is a lowering of adiponectin. Adiponectin is a favorable hormone. We wish we had a lot more of that because that will really promote an improvement and amelioration of these conditions. On the other hand, insulin also has a primary role on the liver. And its role has to do with regulation of hepatic glucose output. So people with diabetes, they wake up in the morning overnight, but my blood sugars are high. And it's because the liver is really pouring out a lot of glucose. There's also gluconeogenesis occurring and glycogenesis occurring there. And that has to do with the impairment of insulin action. So a combination of these two really brings about triglycerides and glucose as the key components that allow for the deposition of fat in the liver. And again, as you can see here in the slide, the consequences are on the one part metabolic, bringing about insulin resistance, dyslipidemia, and all of the other factors in between. So it's important to look at it from here because we do know that our strategies will then be targeted towards these areas where we know are the causes of the condition. Okay, so here is a slide now that illustrates for you what are the components of liver fat. And here again from Harvinen's seminal lecture or research publication illustrates what are the components that bring about an increase in liver fat. And you can see here that all of them are directly proportional. Letter A, that of waist circumference. Letter B, fasting glucose. Letter C, serum triglycerides. And letters E and F being your systolic and diastolic blood pressure. All of these are directly proportional to liver fat. The only thing that's inversely proportional would be your HDL, because you really want your HDL to be elevated so that when there is a reduction in your HDL, you also are promoting liver fat deposition. So these are very important markers that you can use, and they're all components of the metabolic syndrome that we can clinically pick up and monitor in our patients. Now, let me share with you now some work from my colleague, endocrinologist, Dr. Rebecca Lim Alba. I believe she did this in Chinese hospital, where they looked at 164 patients with type 2 diabetes with fatty liver. This was published in our journal of the ASEAN Federation of Endocrine Societies. And these were proven to have ultrasound and FibroScan confirmation. And they found in this particular group of patients that fibrosis or cirrhosis was greater than 55% in this group. What's the other interesting thing here is that when we looked at the ALT, which is commonly what we use as one of our screening also for our patients with metabolic syndrome, diabetes, and the like, is that more than 50% of them did in fact have normal SGPT. So again, that's something that we need to be considering when we're pursuing our diagnostics, as Dr. Janus has already described. Just a few more points from their paper. It was important to note that the variables that promoted occurrence of hepatic steatosis included dyslipidemia, particularly high triglycerides, poorly controlled diabetes, and obesity. Okay, so these are the factors that we hammer on our patients to make sure that they're able to control, and they are indeed variables that increase the odds ratio for developing this outcome. As far as liver fibrosis, in that particular study as well, again, it's glycemic control. If they're poorly controlled, here transaminases factored in, as well as diabetes duration. So patients who've had diabetes for a long period of time, particularly if they're not controlled, and particularly if they're obese, these are really some of the classic factors that we see that can promote progression to liver disease. This was already shown by Dr. Janus, and I just thought it's important for us non-gastroenterologists to think about the non-invasive tests. And it's really, now after he has described, you can do your calculation through the app, be able to do this non-invasive testing and determine your patient's FIB4. And then, have this kind of a guide, as we do for primary care, internists, endocrinologists, cardiologists, and the like, to be able to really figure out where your patient is in the risk stratification scheme. Again, this is coming from his slide saying what are available for us and what we can in fact use and be able to apply for our patients as we think of where they are in their conditions. Okay, so here, part 2 of that clinical pathway, which was developed by a variety of organizations, primarily in the US, have to do with looking at where your risk is and then providing you with the recommendations. And again, it has been discussed in terms of life prevention, weight loss, where the role of pharmacotherapy is. We continue to think about cardiovascular disease outcomes, and therefore risk reduction for that is really important. And of course, we have to achieve good glycemic control, good blood pressure control, control of lipids, control of weight, and to complete it, be away from vices that may affect their cardiovascular outcomes as well. This was mentioned as one likely diet that can be used for patients to ameliorate fatty liver. He already described what this is, but it's primarily carried over or was done in the European countries, where they have a whole lot of these kinds of foods available and are affordable for their population. But here, what it's trying to tell us is that you need a higher consumption of fruits and vegetables, whole grain, more fiber. Again, the use of oil, because they have a lot of olive trees within their countries, fish, and other dairy products, white meat particularly. So the most important part here is reduction in your consumption of red meat or processed meat. And of course, they also use, they drink wines in Europe, and here they were able to look at as well at the effective wine. So what we think about this, surely this sort of diets have a potential to improve liver status, although the efficacy is still limited as far as the data is concerned. And of course, we are always thinking about the cost and the availability that can be the feasibility and practicality for our patients in the Philippines. I think that's really important to note here is that if we are following that they have more of the red and the processed meats, and really less of vegetables, fruit, and if we pattern our diets, what they're eating with a lot of sorts of food outlets that are coming in from the US, etc., where there's more margarine and butter and less of the white meat. And of course, those are certainly diets that will an increase in obesity, so bring about all of those steps towards developing liver fat. So I think for the most part, what we need to be thinking about in patients with a metabolic syndrome is, as I said earlier, I always tell this to my patients, in your hand. It's 5 factors mainly: blood sugar control, lipid control, blood pressure control, particularly visceral obesity, and do it is really the good old lifestyle modification with eating, cut with your caloric restriction, less simple sugars, having your regular physical activity, which are all easy to say. I have more than 20 years of practice in the field of metabolic conditions, and I know that's really one of the most difficult to really carry out for patients in the long run. And I say that with this particular concept in mind, that really lifestyle modification as an intervention is quite complex. We always hammer on the patient before the clinic, but it matters that it is not solely the responsibility of that person before you. Dr. Abarquez, a radiologist, would always say that this is a family affair. Truly, people in the Philippines go together as families and would eat together, not exercise together. So those really come together in terms of how we can bring this all about. It's really well to a certain beyond also individuals and families, as we need to be looking at how our own systems, for example, starting at school, the food, the physical activity that they will have there, our transport systems, how are our patients able to move from one place to another and do their exercise. There are not too many sidewalks that are easy for them to go to walk on, or parks. And therefore, altogether, these are really critical issues on a national scale that we hope we can have this national plan to come together, providing more opportunities for meals, more affordable, healthier meals, and having the opportunities for physical activity on a regular basis. So that I'd like to summarize my thoughts and my reactions to Dr. Janus talk, that I'm very glad that me this afternoon. Indeed, we need to increase awareness of fat liver. The numbers may not be very high, but we're happy that they're not of cirrhosis cancers, but clearly, effect as a condition occurring in metabolic conditions or metabolic. Identifying modifiable risk factors, and we did talk about the components of the metabolic syndrome. Talk to patients, say, Doctora, what medication will I take? To tell them, also pointed out, there's no drug to overcome this, and it's really a Therefore, it's not, again, easy hammer into our to think that there are still a lot of research gaps that we should be working on, particularly the physician side to I always wonder about what hepatitis rates among Filipinos have in terms of its effect on fatty liver. We also want to know specifically what are those predictors to progression among Filipinos. And again, as I said earlier, what diets are probably the most important that we can start putting together that are more fit for the Filipino because they can afford it, they're available, and they're doable to a day-to-day basis, as well as really expanding their opportunities to be able to do their physical activity on a day-to-day basis. So I think that covers my reactions, and we can go into further discussion with that. Thank you, Dr. Su.
Oh, thank you very much. That's Dr. Elizabeth Paz-Pacheco. O, tingnan nyo yung mga hearts, mga palakpak, at saka yung virtual clap natin. Very, very comprehensive also presentation. And I think giving us some very practical tips on what we can do, no? Which I think is really very helpful for our frontliners. Okay, so we're going to go into our panel discussion, and you'll see the positive comments, Beth, no, in the chat box and through the emoticons. Okay, so Raymond, I think we're gonna have a little break with the public service announcement. Go ahead.
That's true. Before we go into our Q&A, we'd like to take this very quick break for our special public service announcement today.
O sige na, anak. Parang kagat lang ng langgam. Kantik o yung kumikiliti lang? Ito naman parang hindi ka pa nababakunahan dati. Akala ko pa naman brave girl ka. Nakakahiya na kay Doc.
Okay lang po, nanay. Ay, ang cute naman ng shirt mo. Favorite color ko rin yan.
Doc, favorite ka rin po ang color nito. Pero ayoko po ng red hunting. Masakit kumagat at takot rin po ako sa blood. Magtutugo po ba ako sa bakuna?
Ah, hindi. Walang dugo sa bakuna. Konting pisil lang, tapos na.
Kakasugat ba ako, Doc?
Hindi ka magkakasugat. Lalagyan lang natin ng plaster pagkatapos para safe. Di ba nabakunahan ka na rin ng contra measles at chickenpox dati? Parang ganun lang din ang bakuna para sa COVID-19.
Natatakot pa rin ako, Doc.
Alam mo ang secret sa pagiging brave. Hindi ibig sabihin na wala kang kinatatakutan. Kundi, kahit natatakot ka, hinaharap mo pa rin ito.
Okay. Ready na po ako, Doc.
Una, pupunasan ko muna ng bulak na may alkohol ang braso mo. Okay? Tapos, mabilis lang na konting... Ayos! Tapos!
Tapos na, anak. Pwede mo nang buksan ang mga mata mo.
Nay, sabi sa inyo, brave girl na po ako eh.
O, heto ang prize para sa'yo, ha? Wow! Bagay sa shirt mo. That's the color of bravery.
Color rin yan for love. Thank you, Doc. Thank you, Nay. Dahil ako po ay mahal ninyo, nagpabakuna na ako.
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the Stop COVID Deaths team to push for pediatric vaccination for children aged 5 and above. We hope you'll be able to share this message along with this video clip to all of your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. We also understand that every one of you are leading busy lives, full schedules. So we have selected some presentations that we will be featuring in its entirety. Pero these are very short presentations po that we lovingly call SED Shorts. And you can find them if you go to https://youtube.com/TVUPPH. Let's start the ball rolling, Dr. Susie.
Okay, so we're going to ask Janus and Beth to open their camera and we'll start with our open forum. No, we have so many questions in the chat box, but not in the chat box, in the Q&A. Raymond, na dami, no? Pero before that, maybe let me sort of start a little bit on by sort of just framing a little bit what the issues are. No? I think the main message is that sabi nga ni Raymond, the weight loss, no? Caloric reduction in calories, diet and physical activity and a healthy lifestyle. No, will give you a healthy liver. So, siguro I'll ask both of you, what are the more common challenges what are the challenges for patients to achieve that healthy lifestyle? Kasi, ano nga, no, parang stressed out, nagtatrabaho, minsan kung ano na lang makakain, di ba? Even if we know what we need to do, it's not that easy to get that done. So, what are some of the challenges that patients come up to you with when you say, okay, dapat ganitong diet natin, ganitong physical activity, etc. And how do you respond to the challenges when they say, ang hirap naman doc, hindi ko kaya yan. So we'll start with with Beth. Beth, ikaw muna.
Okay, that particular question is the most interesting question, but many hours to answer all of those. Because Susie, if you tell me about challenges from patients, and Raymond, I've had, as I said, more than 20 years of practice on metabolic conditions, and day in and out, this is the sort of conversations we have. The Filipino looks at having gatherings and parties as bonding opportunities. It's also a sign of prosperity, and that's why we really fill all our tables with lots of foods, right? So no question yun di ba? And unless we really change our mindset in terms of paano ba maging healthy talagang kumain, that's one part of it only, and the other part, of course, has to do with physical activity. And I did mention sa reaction ko how difficult it is for many of us Filipinos to get their exercise in place, right? So they have nice, simple walking around places that are safe, hindi sila mananakawan, or hindi sila whatever, di ba? Wala tayong masyadong ganon eh. So, and again, depending on where they are living and where the conditions, talagang napaka-limited. And that's why we really have to be able, on a national scale, help them. One other thing that comes to mind, Susie, with your question is, for example, the matriarch of a family. I have one patient na ganyan. She really is the best cook and the best preparer of parties. So I says, you mean we'll have to change our meals and because my husband has diabetes and all that. So even that, right? Very educated. It's really tough to get that going. But all I think that we need to be really focusing, making sure that we can all have this kind of a mindset for thinking and having really a conscious awareness of what we will be eating. It's not easy all the time, as you said. Fast food yung unang pinakamabilis, drive-through dito, or so talagang mahirap. Pero we have to have that conscious way of dealing with it. And I tell my patients, pati yung weighing scale is your friend, because that gives you an estimate of where you are. You know, going up or going down means you've been eating more and exercising less, and the converse. So I don't have an easy answer. It's really...
Okay. Doc Janus, ikaw naman.
Yeah, I think one of the things that's really patients complain about is they don't have the time to exercise. As you said, everybody works, and I don't know. I personally, I also find it very difficult to get myself going with an exercise. So, but when you're there and you're doing the exercise, okay na. Pero yung inertia in starting the exercise, I think, is the most difficult for everybody. The other thing is, and I agree with Dr. Beth, that we really need more sidewalks, we need more parks, We need, and that probably requires a systematic change and maybe a comprehensive plan, not just for fatty liver, but also for lifestyle diseases in general, because fatty liver really goes hand in hand with the other lifestyle diseases. The other thing that's very common among patients with fatty liver is that because of their weight, they have many joint issues. So, and pains. And so it's very hard for them to even start to go on an exercise regimen. So I always say, so that's very difficult to answer. And that's why, again, a multidisciplinary clinic with maybe a physical therapist would be very helpful to design a program for that patient who has physical limitations to exercise, to be able to move around and perform moderate intensity exercise. One just has to be creative. But, you know, for clinicians, it's very difficult to spend that time to be creative with the patient. So really a multidisciplinary clinic will be very helpful to address these issues about exercise and physical limitations.
Yeah, thank you, Dr. Janus. I mean, I think the issue on physical activity and changing the environment, I really like that approach that you have, Nona. We need more sidewalks, you need more places to walk and exercise. Actually, in some other countries, what they do is on the weekends, they open up the schools so that adults can play basketball, they can run, they can whatever, no? So I think the whole way that we organize our life has to be changed because the environment determines your behavior and vice versa, right? So it's like we have to really think outside the box in terms of how do you get people out of a sedentary lifestyle. It's not just the individual or convincing them, but I think you're right. What we need to do is really have environmental change, no? Kasi yun na nga, kung you barely walk, right? Tapos you have to go to a gym. And that's expensive also, di ba? Kaya sabi ko nga sa ibang bansa ginagawa nila, they open the schools on the weekend, even if it's just the weekend, so that adults can be involved in sports, in games, in walking, etc. Anyway, so we have a lot of questions in Q&A, and I'm gonna turn over to Raymond to go through this. Tsaka magaganda yung mga tanong eh. Sige, so Raymond, ikaw muna dito. Sige, go ahead. I will read through them also. Raymond, I think you're on mute.
Yes, okay, sorry. Thank you, Dr. Susie. I chose the very first question just because it repeatedly comes up po, no? And I think people would want to understand, and those who are part of our audience po, no? Is mild fatty liver reversible? Pagka nagka-fatty liver na po ba, pwede pa po ba yung mabawi o tuloy-tuloy na po ba yung pag-fatty liver niya?
Magiging skinny na siya. Skinny liver.
Despite any interventions. Dr. Janus.
Yes, fatty liver. I think that's why we have to talk about this and we have to raise awareness about it. Is because we know that at the moment we don't have drugs yet for fatty liver, but we know that lifestyle intervention, it has been shown in very well-designed trials that lifestyle intervention can definitely reverse fat, it can reverse inflammation, and it can also even reverse fibrosis. So that has been demonstrated very well in well-done studies. So the simple answer would be yes, we can definitely reverse fatty liver and inflammation and fibrosis.
What about those, ano daw, Dr. Janus, mga glutathione, pwede ba yung maging protective sa liver? Yung mga nababasa po nila sa ano.
Okay, it always comes up. And I wish I would never be asked that because the problem with the hepatotropics is that we don't really have yung data to support their use. So napakadami nila and they're not regulated. So hindi natin alam kung yung mga binibenta, meron talagang active ingredient, no? Hindi nga natin alam. So because hindi sila regulated, so hindi sila ganun ka-strict with them. And so because we do not have data on whether they're effective or not, we really cannot say that they're also safe. And so what I tell patients is that mas mabuti pa dahil mahal ang gym, is instead of spending it on the hepatotropics, maybe you can just pool that money for the hepatotropics and spend it on a gym and a trainer. Because the other thing about exercise is that I think when it's structured, or you have a trainer, someone is forcing you to actually get on that treadmill or do this exercise. And I think that would be, I think for me at least, for personally, I think having a trainer really helps force me, because they will call you and say, you did not come yesterday, maybe you should come today. But that would cost money. But so I said that maybe if you spend it on hepatotropics, just spend it on a gym subscription and a trainer.
Raymond,
You know what? Sige, go ahead. Beth, go ahead. Sige.
Janus, there used to be Limarine. Was that ever proven to have any benefit?
There is one study on silimarin, and this preparation is actually a pharmacologic preparation of silimarin that's available also here. So they were able to do a study in Malaysia that looked at this particular preparation, but they had to use a very high dose, 5 capsules of the preparation 3 times a day. And in that study, which was a biopsy study, they were able to show improvement in histology in patients with fatty liver in those given silimarin versus placebo. So there is some proof of concept that silimarin works. The question really is what dose and how are we going to package that dose into the products. If you remember, there are many silimarin products in the market, but when they did how do they call that, yung analysis of whether they have silimarin or not, very few actually had the silimarin dose that they claim that they have. So again, it speaks to the fact that they're not regulated, so it's very haphazard in terms of which ones are reliable products.
Thank you.
Yeah, I was going to comment on the thing about getting people to exercise. Kasi I remember Raymond's the Victoria Health Promotion Foundation in Melbourne. One of the things they do, because it's expensive to get a trainer, is that they have an app where people gather at a certain time, let's say 5 o'clock. There's an app, if you enroll in that, they meet each other at 5 o'clock at a certain place. Tapos saka sila maglalakad or tatakbo, whatever they're gonna do. So really the community needs to be engaged in trying to find out how to get people to move around some more. Raymond, while we're at the discussion on different products, ito, L-carnitine or Godex.
Yes,
Dr.
okay.
Janus.
Dr. Janus, there's another question related to L-carnitine, di ba? I think yung mga fit and right, mga ganon. And I remember in your presentation, you said no more of the simple, yung may mga juices, yung mga sweetened drinks, ganyan. Pero people have this, I think, conception na yung sa fit and right na L-carnitine, that's really part of, will be helpful as part of that. Your opinion?
I think talagang this question comes up very often, and again, I wish there was data to support the use of L-carnitine, phospholipids, robust data to support their use and what dose with which to use. Because again, the doses and the preparations that are in the market are all over the place because they're not regulated. So we don't know which one would really work and which one would be safe. So I think my short answer is, let's go with what's proven to be effective, which is lifestyle modification. I know it's difficult. And sometimes giving these medications can distract the patient from what is important, the lifestyle modification, because they have this false sense that they're doing something. May iniinom naman ako. So siguro okay nang hindi ako mag-diet ngayong month na to or something. So I feel that may play a role in complacence with the lifestyle modification.
Yeah. Raymond, there's a comment here by Dr. Ludan. You want to read that? Oh, okay.
Where is that?
It's in the Q&A. She was talking about kids.
Okay, go ahead, Dr. Susie.
Okay, so this is from Maria Patricia Ludan. Possibly due to the diet, lack of exercise, and lifestyle, especially during the pandemic, I'm seeing now more pediatric patients as young as 7 years old with elevated levels of cholesterol up to 2 times the upper limit. And some are also newly diagnosed diabetics or even pre-diabetic. May I know if these patients need to be screened already for NAFLD? Will they need to undergo abdominal ultrasound? Can the FIB4 index be used for the pediatric age group? Nice. Okay. Dr. Janus, go ahead.
Yeah, it's unfortunate that we're both adult physicians here with Beth. And if there are pediatricians here, maybe we could ask them to chime in. But the reality is that pediatric NAFLD is real, and it occurs. And I think part of it is, we find children who are overweight and obese cute. So I think we have to, I don't know if that has to be changed. Cirrhosis and advanced fibrosis has also been described in children, but mainly in the adolescent group, because they have had fatty liver and insulin resistance for a while. So most of these children who in the adolescent group have advanced fibrosis actually have other features of metabolic syndrome, diabetes, and they have acanthosis nigricans, very, very prominent, under their armpits and in the back. And so talagang meron silang insulin resistance. So they do need to be identified. I think if you have patients with the same high-risk features as adults, although pediatric NAFLD is less well-studied at the moment, we can screen them with ultrasound, and we should already institute measures to curb the fatty liver, and also if they're overweight, to make sure that they reduce their weight. I think it should not be different. The use of FIB4, however, is not very well validated in the pediatric age group. There is a FibroScan probe that is designed for pediatrics. And so some of the centers that have FibroScan machines have the pediatric probe, and that has been a little bit more validated for pediatrics compared to the other non-invasive tests.
Okay, we have another question from one of our doctors, professors na kasama, no? So, very well-known internist, Dr. Dante Morales. Comprehensive lecture, Dr. Janus. Please expound more on the difference between elastography versus FibroScan in terms of accuracy, price, predictive value, availability, etc.
Si Ma'am Beth yata may sasabihin, ma'am, kanina.
Okay, sige, Beth, go ahead.
That a part of that was the point that there's a changing phenotype for diabetes. We used to think about diabetes being older. Now we're seeing them really younger individuals. So the age 20 to 30 to 40, we're seeing a whole lot of them. And they have due to increasing obesity as well. So I guess hindi lang yung pediatric ang nagkakaroon, but now really we're not talking about older people with type 2 diabetes. This is really changing dramatically. It's occurring in younger people. Kaya talagang increased obesity rates, increased visceral obesity, lead diabetes and the cardiovascular events at an earlier stage. So we really have to be more serious with all of our lifestyle measures to put a stop and do prevention. Otherwise, it's really going to be very, very a big problem for the next decade or so. Sorry, yeah.
Okay.
Okay, thanks a lot. Sige, Janus, let's answer that, Dr. Dante.
Yes, so thank you, Dr. Morales. The question, of course, is asking about the elastography techniques. So because we can't really do biopsies on everybody, we rely on non-invasive tests. And one group of non-invasive tests are the elastography-based techniques. And this include FibroScan, which is transient elastography, and shear wave elastography. These are the two most common available in the Philippines. Although I think there's more with FibroScan these days. And so in terms of accuracy, I think they're pretty good. They're both similar in terms of their accuracy, except that FibroScan has more validation studies. So it just has more validation studies. Because it has more validation studies, it's what has penetrated the clinical practice guidelines. The cutoffs, however, are very different. So just be careful if you want to use the diagram that Dr. Beth and myself used. The cutoffs there are for FibroScan or transient elastography and not for shear wave elastography because the cutoffs are different. In terms of price point, they're actually pretty similar. I've asked around the price point for shear wave elastography and for transient elastography. Thank you.
Yeah, thank you very much. I think before we leave these topics on diagnosis and treatment, so Dr. Janus, you were saying that there is one drug that's being studied that can be used for the treatment of NAFLD. Can you talk a little bit about this drug and where are we in terms of clinical trials and use even in an experimental nature in other parts of the world?
Sorry, I mentioned the one drug, obeticholic acid, which actually has completed its study, but they're following up the patients. And the results had shown improvement in fibrosis, but very, very small improvement in fibrosis, but statistically significant. The problem was a lot of patients had side effects, mainly itching. They had a lot of itching, and their LDL levels went up. So they're not sure how this will affect the overall clinical management of these patients. So that's why they're still waiting for the longer term data to see if this should be approved because it hasn't been approved for the treatment of NAFLD, even though there was a positive result. There are many molecules that are being tested. The problem with fatty liver is that it's probably many, many things in one disease. And so we really need to have a multifaceted attack on it. And so there are molecules that looked at homeostasis or on metabolism. There are those that look at antioxidants for anti-inflammatory, and there are anti-fibrotics. And maybe we would have to end up with several drugs attacking several points in the pathogenesis of fatty liver towards fibrosis. So there will be the first clinical trial on fatty liver disease on NASH will be started soon in the Philippines. So this will be the first clinical trial that will be available here. We don't have the drugs, but there are many molecules that are being tested.
Yeah, thank you very much, Dr. Janus. Raymond, nako, we're going close to the top of the hour, pero you might want to pick up some questions from either Facebook or YouTube. We still have a few minutes to take maybe 2 questions, and then we'll have to go to our closing.
Sige. Dr. Susie, this one is more on the extreme end, and I like to pose it to Dr. Janus. How possible is it that that by having NAFLD, I may eventually need a liver transplant?
So remember in my slides, I presented several cases at the start, and I showed a pyramid. And fortunately, there's a big universe of fatty liver patients, millions, but not everybody will develop complications of liver disease. And so the ones that really go on to have progressive liver disease are those with diabetes, those who are obese. So those are the 2 main things that we have to pay attention to. So, but as we had discussed previously with you, we can prevent the onset of these complications by paying attention to our lifestyle. And by paying attention to our lifestyle, we might be able to, I think there are well-done studies that have looked at lifestyle and the prevention of diabetes. Those are without doubt already. And so I think what would I say? The likelihood of developing cirrhosis and liver cancer is real and needing a liver transplant, but it is small compared to the entire universe of fatty liver patients, and it can be prevented by identifying patients early and instituting lifestyle interventions.
Yeah, I was going to ask because I saw this somewhere. I'm not sure if it's in the chat or the Q&A. What's our view on virgin coconut oil? Maybe that's for Beth.
Okay, well, I used to be with the Philippine Lipid Atherosclerosis Society, and we were trying to look at doing studies on coconut oil. And I really hope somebody's listening here that we can continue to progress with those studies, because until we really know for sure, we don't have had a hardcore facts at this time for that. But coconut, Janus, you're nodding.
No, Mom, I don't know. I know I asked a friend, I called a friend before this to ask about a substitute for olive oil, which is in the Mediterranean diet, because number one, olive oil can be expensive, and number two, not a lot of people like olive oil because it has a certain smell if you're frying, for example. But it looks like ang pinaka parang parehong profile sa olive oil is canola oil. Although I know there were some messages in the chat group that coconut oil was good, but I thought that someone can correct me if I'm wrong, coconut oil has a lot of saturated fat. So, and in non-alcoholic fatty liver disease, there are 2 things to avoid, saturated fats and sugar, table added sugars, sucrose and fructose.
Okay, thank you very much. All right, we will have to start wrapping up. And Raymond, let's answer the quiz.
Thank you, Dr. Susie. So for our quizzes po, we usually want to be able to hear the correct answer from our experts. So for our first question, which of the following risk factors or conditions are associated with fatty liver? We'll ask Dr. Beth for the correct answer, ma'am.
Okay, so I guess they all answered correctly because indeed we were talking about risk factors relating to the metabolic conditions, and all of this are part of those, particularly obesity, diabetes, and dyslipidemia.
Ayun. Okay. So for the Zoom, 84% chose all of the above, and then for Slido, it's 85%. So hopefully our audience was able to keep track of the correct answer. For our second question, ano po ang porsyento ng non-alcoholic fatty liver disease, Dr. Janus?
Well, we don't have, and we hope that we could in the future do a well done study on prevalence, but small cohorts of wellness clinic patients peg it at around 38% or 1 in 3 patients will have fatty liver. It's a lot.
Okay, thank you so much. Which is interesting, and I don't know if it's a surprising coincidence that 38% of those who are respondents in Slido chose yung ating 35%. So hopefully that we'll be able to remember that it's a third in terms of the prevalence of NAFLD. And then lastly, again, Dr. Janus, most patients with fatty liver, what do they feel?
Actually no symptoms. Yeah, which that's why some people, say it's a silent disease, silent epidemic. So asymptomatic.
Okay, thank you so much. Before we wrap up and really try to get the final messages from our speakers, we'll go first to our evaluation poll. This evaluation poll will include 5 questions. It's a 4-point Likert scale, and we'll give this time to our speakers to really craft maybe a 1-minute final message to our audience. For the first question here in the evaluation poll, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. We do not send out a separate evaluation poll. Ito lang po iyon. So we will not be closing this evaluation poll until towards the end of the webinar as we move on to the final messages of our speakers. Dr. Susie?
Okay, thank you very much. We'll have Dr. Beth first give her parting message. Beth, the floor is yours.
Thanks so much for having me part of this, Janus. Thanks for your invitation to be part of this important webinar. I really think tama yung title mo. We should really care and about fatty liver. And the point here, though, has to do really with not just the individual, the family, the community. And I really pray that our national leadership will help us providing everyone, every Filipino, good, healthy food choices, affordable, and opportunities for safe, physical activity. That's the only way we can really move forward. And the burden really of lifestyle conditions, diabetes, hypertension, dyslipidemia is upon us. And fatty liver now. So altogether, we really need to put our act together. So thanks again. It was wonderful spending this.
Okay. Thank you very much. It's Dr. Beth Paz-Pacheco, who is a consultant at the Philippine General Hospital for Endocrinology. Okay, Dr. Janus, go ahead.
Yes, hi. Thank you. Again, thank you also for the invitation. I didn't know how it would fit into Stop COVID, but Raymond explained it to me. And it was an honor and a pleasure to really talk about this here and hopefully raise awareness about it. The reason I asked Dr. Beth to be the Rreactor and not another gastroenterologist is to illustrate the importance of all of us coming together to address this, I dare say, this epidemic. I think it is. If there is the diabetes epidemic, there's also the NAFLD epidemic that's coming. So I think thank you again, and I hope everybody got something from the webinar this afternoon.
Thank you so much. That's Dr. Janus Ong from the Department of Gastroenterology, Internal Medicine at the Philippine General Hospital. Okay, so thank you so much for your presentations. I think you'll see how much our audience appreciated the time and the effort that went into preparing and your very thoughtful responses. Maraming salamat. Okay, so to wrap up, we have none other than our Deputy Director for the Philippine General Hospital, Dr. Stella Jose, who will give the closing remarks and a summary. Stella, over to you.
Good afternoon, everyone. We have a very excellent lecture from both Drs. Beth Paz-Pacheco and Dr. Janus Ong. And I hope you all review the recording of this lecture. Dr. Janus Ong expressed the burden of the disease of NAFLD, and he said that non-alcoholic fatty liver disease will eventually become non-alcoholic steatotic hepatitis, and this causes liver injury and liver cancer, can lead to cirrhosis and eventually liver cancer. And he explained the worldwide prevalence. In Manila, we have a 38% prevalence rate, and it is more prevalent among diabetes mellitus patients, 55.5%. And he also mentioned, as I said earlier, that NASH can lead to hepatocellular carcinoma. Now, the diagnosis of NAFLD and NASH, when we say NAFLD, it is the presence of hepatic steatosis by imaging or biopsy. So all the rest are no. So no significant alcoholic consumption, no secondary causes of hepatic steatosis, and no other cause of chronic liver disease. No, it is only the presence of hepatic steatosis by imaging or biopsy. What about NASH? NASH is diagnosed only by biopsy, and he explained the test that can be done, the non-invasive test. But what is interesting is the link up with type 2 diabetes mellitus and the metabolic conditions. In these patients, they have elevated liver enzymes, and these are high risk for fibrosis and probable liver disease. Okay, so he mentioned about the risk stratification in NAFLD, and the commonly used non-invasive tests are, these are the simpler ones, the fibrosis score and the NAFLD fibrosis score, the AST over the platelet ratio, and the index of this, also the AST/ALT ratio. So these are the simpler tests that they can do. However, if you want a more detailed test, or since you cannot do biopsy on those patients, the tests that can be done are the vibration-controlled transient elastography and the 2D shear wave elastography. Okay, so these are available, as he said, these are available here in the Philippines. And what I would like to emphasize are the food that we must eat to prevent this from happening to us. So he recommended the Mediterranean diet. Okay, so this consists of nuts, seeds, legumes, whole wheat grains, fish, walnuts, fruits and vegetables, and olive oil. We should also have an active lifestyle, so we can do mental well-being management, such as yoga, aerobic exercise, resistant exercise, and we should reduce sedentary behavior, so we just don't sit around. Okay, and we should avoid processed meat and sweets, sugar sweetened beverages, alcoholic beverages, and high fat sugar diet. Okay, so that one is very clear to all of us, and we should have. He mentioned that losing 7% to 10% leads to the resolution of NASH and improvement in fibrosis. And in his summary, he mentioned that NAFLD is an important public health problem. It can lead to cirrhosis, liver failure, and hepatocellular carcinoma. NAFLD, being a multisystem disease, is associated with extrahepatic complications such as cardiovascular disease, chronic kidney disease, diabetes, and extrahepatic cancers. Fibrosis is the most important predictor of clinical outcome in NAFLD. And he mentioned the determination of fibrosis severity, the risk stratification. we should have lifestyle modification, and this is the cornerstone in the management of NAFLD. Pharmacologic therapy can be considered in some patients, but aggressive management of associated metabolic conditions is an important component in the multidisciplinary approach to NAFLD. So that is very well, that is very clear in his talk. And Dr. Beth Paz-Pacheco centered on the harmonized criteria for the diagnosis of metabolic syndrome. I think all physicians should be aware of this. Now, the first, because it really summarizes everything that she said, the first is the elevated, when you have a high waist circumference. So our waistline is high. So that is but she said that this depends on the population and the country where it is. It depends on the country. Okay, so the second is an increase in the triglycerides more than 150 milligrams per dl, a low HDL-C, and in men it is less than 40. In women it is less than 50. A high BP, a systolic of greater than or equal to 130, and a diastolic greater than 85. And when you have a high fasting blood sugar count. Okay, so she explained it very well and its effect on the liver. That's why in many studies, no, they focus on the waist circumference, fasting blood sugar, serum triglycerides, serum HDL, systolic BP, and diastolic BP. And it has been shown to have a very good correlation in the development of metabolic syndrome. And she mentioned modifiable factors for the prevention and control of NAFLD. First is we should control the hyperglycemia, the hypertriglyceridemia, and low HDL cholesterol, the hypertension, the visceral obesity, the high simple sugar intake, and physical inactivity. So all of us, we should be conscious of these factors. And I have seen patients who are morbidly obese, and also children who have polycystic ovarian syndrome, and these children are very obese. And a big factor here is the family. Whatever the mom cooks is what also the children will eat. And so when you see an overweight patient, the overweight mother also has an overweight child. No, so in summary, Beth Paz, I knew her as Beth Paz. Beth Paz-Pacheco mentioned we should have increased awareness of fatty liver, and we should care about these conditions. We should have an early diagnosis and prevention is the key. Identifying the modifiable risk factors to prevent progression. And we should recognize the association of the components of metabolic syndrome and the control of risk factors such as blood sugar, the weight, cholesterol, and hypertension. And there is no single drug that is advised for this. It's really about lifestyle change. Thank you very much to our speakers, and back to you, Susie.
You're on mute, Dr. Susie. You're on mute.
Thank you very much, Stella. So that's Dr. Stella said, the Deputy Director of Philippine General Hospital. I don't know how you do it, but you gave us an excellent summary. Okay, next week. Okay, some of you were already asking, bakit tumataas yung myopia? Diba? Ako naman, Raymond, naisip ko, kung lahat tayo may myopia, di wag na tayo lahat magsalamin. Baguhin na lang natin yung mga size ng mga fonts, mga ganyan. I'm just joking. But we will talk about visual acuity in children with a very well-known ophthalmologist next week. So for those of you who are curious, or yung mga anak nyo lahat may myopia, o kayo nagka-myopia na rin, no? We are going to talk about that next week. And so join us. It's not a COVID topic, but I think Raymond already said earlier that it's really a huge problem in a place like Singapore no, and increasingly in China and also in the Philippines. So we're gonna have Dr. Leo Cobillan, who's going to be speaking next week. Abangan nyo po yan. He's the expert in that field. Okay, over to you, Raymond.
Thank you, Dr. Susie, and thank you to the final messages of our speakers as well as the synthesis and closing remarks from Deputy Director Stella Jose. You can see in front of your screens the evaluation poll that we have for this webinar. So at least 93% of our attendees strongly agree to all of the statements here. Very, very well received po ang ating webinar, and we hope you'll be able to remember all of the reminders from Dr. Janus and Dr. Beth after this webinar. But before we close, we'll take this opportunity to thank the very hardworking team behind the Stop COVID Deaths webinar series. So without each and every one of you, we won't be able to churn out quality content week after week. Maraming salamat po sa inyong lahat. And finally, all 119 episodes or webinars po natin, they are archived if you go to youtube.com/TVUPPH. And then after today, it will be 120 episodes in the TVUP YouTube channel. So abangan nyo po iyon. We hope you'll be able to watch them again on the playback. At pati na rin po ang ating SCD shorts. This finally closes our webinar po for this week. Ayan po on your screens, no? And we hope you will be able to see each other again next week sa ating next Friday from 12 noon to 2 p.m. It's a date.
Together we can stop COVID deaths.
So keep safe, keep healthy, and see you online.